Dear friends, good morning, good afternoon, good evening, according to where you are located in the world. It's my pleasure to start with a new series of webinars from the International Society of Gynecological Endocrinology, who will precede our Congress next year in May 2024. Today, we will have a fantastic topic, which is menopausal obesity. And we have two speakers. One, she is Professor Maria Augusta Maturana, and the other is our friend and colleague, strong member of the board, Professor Fred Naftolin. Maria Augusta Maturana, she will speak about what is the menopausal obesity and how can it be defined clinically. She is an MD, Doctor of Science and Philosophy, and as gynecologist and obstetrician with a diverse academic background encompassing master, doctoral, and postdoctoral research. She is now located in Brazil. She's Brazilian from Porto Alegre, and her expertise is lies in steroid sexual hormones and their interplay with cardiometabolic risk factor among women going through phases of menopause, transition, and postmenopausal period. More recently, she has been dedicated in studying the interplay between sexual hormone and female obesity. And this is just the topic of today. And Maria Augusta, I will leave you the microphone. You can share your screen and you will have a presentation. At the end of that, I remind you to open also your microphone. At the end of that, I will introduce Professor Fred Naftolin for his lecture. Thank you very much.
Thank you. And thank you for your kind words, Dr. Genazzani. I would like to thank for the invitation I received from International Society of Gynecology and Endocrinology to present the topic. And a special thank you also to Professor Naftolin. Thank you for everyone watching. I am speaking from Porto Alegre. This is a photograph of Porto Alegre. Porto Alegre is a city in the south of Brazil, and now it's around 10 o'clock a.m. And speaking about obesity, and particularly about female obesity, is a complex topic. I will strive to be concise to allow more time to my co-presenter and for discussion. In this sense, I will divide my presentation in three main sections. What is obesity and how is related to cardiometabolic risk? And the second, weight gain during the menopause transition in post-menopause period, state-of-the-art studies. And finally, menopausal obesity, what is and how it can be defined. What is obesity? The concept of obesity goes beyond simple excess fat. According to the WHO, obesity is defined as an abnormal or excessive fat accumulation that presents a risk to health. Classically, obesity has been considered a risk factor for development of several diseases. However, increased evidence demonstrates that obesity has a chronic and progressive disease per se. Obesity was initially acknowledged as a disease by the WHO in 1948. But it was only after 2013 that various medical societies and countries formally recognized it as such. The current knowledge allows us to classify obesity as a chronic, progressive, and recurrent disease associated with reduced life expectancy and reduced quality of life. Obesity is not an individual choice, but a complex and multifactorial disorder influenced by genetic, environments, behavior, and metabolic factors. Obesity usually is defined using BMI or body mass index, cutoff to reflect the associated health risk. However, there is a spectrum of risk observed among individuals with similar BMI, and obesity is a heterogeneous condition, and calculation of BMI, while easily performed in the clinical setting, obscures issues such as risk for disease and also limits diagnostics and management. To illustrate this, I'd like to mention the large study conducted by Wildman et al., which showed that around 30% of obese individuals exhibit metabolic health. The same, meaning they do not suffer from hypertension, dyslipidemia, or disruption of glucose metabolism. On the other hand, comorbidities occur in 20 to 30 of people with normal range of BMIs. Obesity-related cardiometabolic risk. The impact of obesity on the cardiometabolic risk involves some aspects. One of them is the body composition, the percent of fat mass, and the proportion between fat mass and free fat mass, especially lean mass. However, as data from imaging of fat deposits has increased, it has become clear that the risk of developing fat-associated disease depends much more on the distribution of body fat than on the total mass of adipose tissue. Here's a quick reminder of physiology. Adipose tissue is the main lipid store depot in our body. White adipose tissue, or WAT depots, are made up superficial adipose tissue, which correspond to around 80% of total VAT in the body and has been considered protective. And VAT, or visceral adipose tissue or ectopic fat, corresponding to 10 to 20% of fat in males and 5 to 10% in premenopausal females. VAT deposition, especially abdominal, hepatic, and around the heart, are closely associated with cardiometabolic risk. Then, in conclusion, body fat distribution and entire adipose tissue function, rather than total fat mass, better predict insulin resistance and related complications at the individual level. Body fat distribution is a key factor in obesity heterogeneity related to cardiometabolic risks. VAT, or ectopic fat, is associated with metabolic disease and considered metabolic detriment, as it produces pro-inflammatory mediators. And it's associated to entire adipose tissue function, or sick fat. The concept of sick fat or adiposopathy is a recent concept in medicine, in meaning a pathologic response by the adipose tissue to a stimulus. And adipose tissue dysfunction is characterized by limited expansibility, altered lipid metabolism, change in adipokine secretion profiles, reduced vascularization, increased fibrosis, and enrichment of pro-inflammatory immune cells. There is a significant individual variation in how much fat and where the fat is stored. Factors that may influence these include aging, race, environment factors, and sex hormones. Fat compartments change during the menopause position. In this study of Sowers and colleagues, the authors showed that fat compartments change during the menopause transition. This study included 540 premenopausal women or early perimenopausal participants aged 40 to 55 years old. And this is an arm of SWAN study. And bioelectrical impedance was made to measure percent of body fat and other measurements. And the table shows the relative change in body composition. In this period of evaluation, it's about 6 years, the authors describe a higher increase of fat mass compared with weight and BMI. We can see BMI is increased about 4%, and fat mass increased around 10%. There is an increase of waist circumference, about 6%, and then there's 10% of increase in fat mass and 1% of decrease in skeletal muscle mass that persists after adjustment for chronology. This study demonstrated that accelerated gains in fat mass and losses in lean mass are dependent on the menopausal transition rather than aging per se. Similarly, this publication of Greendale and colleagues showed that menopause transition and menopause are associated with weight gain and changes in other aspects of body composition. The graphs show the weight, fat mass, increase of fat mass, in decreased loss of lean mass. At the start of the menopause transition, the rate of fat gain doubled and lean mass declined, leading to a 6% of total gain in fat mass over the 3.5 years long menopause transition. Proportionally, the increase of fat mass is much higher than the absolute weight gain because it is accompanied by loss of lean mass. Then this study is a classic, and we can see during the menopause transition, the weight and BMI increase, but much more fat mass. And we have a loss of lean mass. In addition, intra-abdominal visceral adipose tissue increased during the menopause transition and postmenopause period. In this publication of SWAN study, the authors showed that VAT, or visceral tissue, trajectory relative to the final menstrual period. He is the final, the point 0. The analysis showed no linear trajectory of VAT with 2 points of inflection. And the authors classify like block 1, block 2, and block 3. And the inflection of trajectory of VAT with 2 inflection points, a period of 2 years before in this period and 2 years after final menstrual period. In this period, VAT increase more. We can see more increase of VAT, and then VAT increased significantly by 8.82% per year in segment 2 and 5.8% per year in segment 3. This can show you that non-linear trajectory in DNT, and this is a special period of vulnerability to increase of VAT. Then VAT acceleration was independent of aging, lifestyle factors, and overall adiposity. And finally, in addition to having greater abdominal visceral fat, postmenopausal women have greater fat deposition around the heart than premenopausal women. This study is the one arm of SWAN study, is a SWAN cardiovascular fat study, and was included 456 women in premenopausal or early perimenopausal and late or postmenopausal women. And CT was used to evaluate, to measure the volumes of cardiac fat. The authors showed that all compartments of intrathoracic fat are increased in menopausal women. Cardiac VAT is substantially associated with subclinical atherosclerosis, and then peri and postmenopausal women had 9.8 more EAT or epicardial adipose tissue and more 40.7 more PAT, paracardial adipose tissue, and more 11 of total heart adipose volumes than pre and early perimenopausal women, independent of age, obesity, and all other covariates. Then her fat deposition has been linked to cardiovascular risk. Good. What is menopausal obesity? During the reproductive period, under physiological levels of estrogen is being associated with positive metabolic profile, low inflammation, and low cardiovascular risk. In menopause transition, during the menopause transition, the estrogen levels decrease, and we have the higher or increase of VAT during this period, and a loss of lean mass and CAT or SAT, subcutaneous tissue. Then menopausal obesity is a special obesity related to a set of factors associated with loss of lean mass, increase of fat mass, and rise in ectopic deposition. In postmenopausal women, like you have a decrease of estrogen levels, we have higher VAT or visceral fat and bad metabolic profile. Then menopausal obesity is a specific middle-aged women's obesity, and the absence of estrogen seems to have a central role. The metabolic impact of menopausal obesity is not the absolute amount of fat gain during menopausal transition and postmenopausal period. but seems to be directly related to ectopic fat. Menopausal obesity is a low-risk entity that may progress to high-risk menopausal obesity, or HRMO. The main determinant of cardiovascular risk seems to be the increased presence of visceral adipose tissue, especially in mediastinal and paracardial and epicardial fat. Rise in ectopic fat deposition is associated as dysfunction of fat. And in this sense, in this context, it's important to have an accurate test to measure ectopic fat to enable good evaluation of cardiometabolic risk in these patients. In this context, the evaluation of body composition and body distribution is a great clinical importance in these patients. Many different techniques have been used to assess fat mass. I present here a range of methodologies that have been utilized in clinical research, organized in inverse order of complexity and accuracy. At the top, there are anthropometric measures, body mass index and waist circumference. BMI is an accessible and reproductive surrogate of fat mass and the most common anthropometric measure used in clinical and epidemiological settings to identify individuals with increased adiposity. It offers convenience, safety, and low cost, but cannot differentiate between lean body mass and fat mass. On the other hand, waist circumference is an indirect evaluation of abdominal fat and an indicator of central obesity. However, it has limitations. Cutoff points of waist circumference vary with sex and ethnic groups, and there is no consensus on the best anatomic location to measure waist circumference. BNI as a bioelectrical impedance is a easily accessible and reproductive surrogate of fat mass. It is useful in inter-individual comparison. This is affected by hydration. Ultrasound is the other methodology. Is most useful in hepatic fat evaluation in clinical practice, and skill is necessary. And finally, DXA, whole body composition approach. Although DXA is a direct measurement of fat and a better measure of adiposity than BMI, it doesn't directly distinguish between visceral and subcutaneous fat. And finally, we have CT, computed CT and MRI that directly measure VAT areas and volumes and thickness of fat. And these techniques are considered reference methods for evaluation of visceral fat. Compared to MRI, CT is less likely to be influenced by breathing artifact, and the radiation for CT limits its use. In summary, Obesity is not an individual choice, and obesity is a chronic, progressive, and recurrent disease associated with reduced life expectancy and reduced quality of life. The menopausal transition and menopause are associated with weight gain and change in body composition with rise of VAT and ectopic fat. Menopausal obesity is a specific middle-aged female obesity, and the absence of estrogen seems to have a central role. The metabolic impact of menopausal obesity is not that the absolute amount of fat gained during menopausal transition and postmenopausal period, but seems to be directly related to VAT and ectopic fat increase. And menopausal obesity may progress to high-risk menopausal obesity. The main determinant of cardiovascular risk seems to be increased presence of VAT or visceral tissue, visceral fat tissue. We need an accurate test to measure ectopic fat in order to enable a better evaluation of the cardiometabolic risk in these patients. I would like to thank to International Society of Gynecology and Endocrinology once again for the invitation. And this is my email and my care code to professional Instagram. And I will know here the to Dr. Naftolin, and I am open to further discussion regarding this matter. Thank you.
Thank you, Maria Augusta. Now we have already received some questions, and I invite all of our the people who participate to write their question in question and answer. And then now I will give the microphone to Professor Frederick Naftolin. Fred is an MD, Doctor of Philosophy, and the former chair of Gynecology and Obstetric Department at McGill and at Yale University. He was co-investigator of the Kronos Early Estrogen Prevention Study, and with more than 900 publications and 17 books, his special interests are estrogen, menopause, and menopausal hormone therapy. Fred, you will present a lecture on is it time to prevent high-risk menopausal obesity with estrogen treatment? Fred, you have the microphone.
Thank you very much, Andrea. It's a pleasure to address this important subject, somewhat neglected for the reasons that Augusta told us about. It's a difficult subject to actually measure clinically. One has to actually look for visceral adipose tissue and for loss of lean body mass in order to understand why the patient has insulin insensitivity and increased inflammatory reaction, etc. But in fact, it can be traced in a certain number of cases to what we call high-risk menopausal obesity. It's been a pleasure for me over the past several years to work with Augusta and to understand better how this comes about. Now let me see, it should turn, but it's not. There, okay. So to take up from what we heard from Augusta, menopausal obesity is a normal occurring low-risk entity. In fact, about a third of women who have obvious menopausal obesity are perfectly healthy from a metabolic standpoint. So just being obese does not mean that they do or do not have a superimposed problem with such things as insulin insensitivity and increased inflammatory signals. On the other hand, a certain number of women will progress to what we have termed high-risk menopausal obesity, which is accompanied by, or perhaps driven by, the accumulation of subcutaneous, of intra-abdominal, intrathoracic fat, which makes one susceptible to complications, particularly cardiovascular complications. It has been known generally from cross-sectional studies that those women who receive estrogen treatment during the menopause seem to have a prevention of these risk factors. And on occasion, it's been shown that, in fact, obesity is not as obvious in women who are taking these medications, but in general, these have been cross-sectional studies and not designed to assess what really is happening. They are just taking snapshots of what is happening at one place or another, and then making inferences such as whether estrogen treatment or menopausal hormone treatment could be administered in order to avoid such problems. Why is fat so problematic, as Augusta has already told us? It has to do with the effect of estrogen on the adipose tissue expansion. In the case of the premenopausal women, in the lower part of this really nice scheme that's shown by Stein, that you can see that while premenopausal estrogen levels can regulate the amount of adipose tissue, they generally do this by causing more cells. While on the other hand, when you get into estrogen depleted situations, such as you see at the top of this drawing, the lower estrogen causes hypertrophy. So individual cells begin to grow. You get more fat, but most importantly, during the growth of the individual cells, they become stressed and they start to send out inflammatory signals, and they start to send out signals that decrease the sensitivity to insulin. And since they are such a large part of the body, you can get a body-wide increased inflammatory response and increased or decreased insulin sensitivity. It's very difficult to address this whole problem from studies that have been done, because they are mostly cross-sectional and they don't have a particular endpoint that is made to look at fat. So I'm going to concentrate most of my remarks on one study, which is the KEEPS, the Kronos Early Estrogen Prevention Study, or KEEPS, which was a 4-year study. So it's a prospective study that looked at the effects of conjugated equine estrogen, which was given orally, or a transdermal estrogen, which is estradiol, given by patch, with a periodic exposure to progesterone to kind of mimic the cycle. So this is quite different than, for example, Prempro, which is a constant exposure to both conjugated equine estrogens and progestin. So this is, like most randomized prospective clinical trials, is itself unique. And what I'm going to tell you about, you should not infer on other studies. All randomized clinical trials are really only valid in terms of the group that is studied. It's very important to define the group. In this case, these women were healthy. That is, they had low cardiovascular risk factors biochemically, and they had a low cardiac calcium score that showed that they had not they had not yet developed cardiovascular disease. None of them were smokers. So these are, for example, in contradistinction to the first reports from the WHI, where the women had many of these things and were much older. These women were very healthy. They were, in fact, perimenopausal within the first few years of their menopause. So you have to keep everything in perspective. This study applies to these women. In general, this is what was found during the 4 years of observation of the patients. That is, that the women who took placebo did exactly what Augusta told you. They gained BMI, and in fact, the oral conjugated equine estrogens, CEE, had the same picture. That is a general increase in body mass, no matter how you measured it. It's quite interesting that transdermal estradiol appeared to be was associated with a fall off of the BMI during the 4-year period. So here's a difference between these agents, and how could that come about? Well, one possibility is that the estrogens that come in by mouth almost immediately go to the liver and then induce proteins that can be quite disruptive, while something that comes in to the systemic circulation, like the patch, has to first circulate before it gets to the liver, so the effect is reduced. And here you can see a kind of a little drama that Mitch Harmon made, so you can see how this develops. It comes into the systemic circulation, while oral estrogen has to go directly to the liver. When it goes to the liver, you get decreased anti-clotting factors, you get increased clotting factors, you get increased C-reactive protein, which is a marker of inflammation. You get increased certain kinds of potentially dangerous cholesterol. On the other hand, when the patch sends its content, in this case estradiol, it gets into the systemic circulation and then has to go all the way around before it finally reaches the liver, and then may cause some of these effects. And this has been seen, for example, in these two studies on the amount of thromboembolic complications. Thromboembolism is quite reduced among women who have transdermal versus oral estrogen treatment. What about the visceral adipose tissue that Augusta has so well designated as the criminal in all of this? And it is. And here you can see a CAT scan that is looking across the thorax, and you can see the cardiac mass within, or the pericardial mass of fat around the within the pericardium. So here you can see the pericardium is kind of marked out by that white circle, and then you see how the fat collects around the heart, and literally it invades the cardiac vessels. When you look at these at autopsy or at surgery, you can see that there is literally fat attached to the coronary vessels, it's pretty impressive. If you start to try to measure these things, again, using the KEEPS patients, here at the end of the 4-year period, you can see quite a difference in the amount of epicardial EAT or pericardial fat. And as you can see, I don't know if I can bring, yeah, here's an arrow. You can see that on oral, with oral conjugated estrogen, you have a considerably different picture of the pericardial fat. Here you see it; it's significant. It's not so significant with the epicardial fat. And this has to do probably with the number of patients who could be brought back at that time for a CT scan. If you study this further, and this is a much more complicated, in this case, El Khudri, using again the same KEEPS women, tried to compare the effects of conjugated estrogen versus estradiol, and compare them with changes in the carotid artery intimomedial thickness, because the carotid artery intimomedial thickness increases with age in postmenopausal women. And I thought that he could only come up with a relatively soft conclusion, that it appeared that while both of them may have had some effect on the index that was made compared to the actual CIMT changes, that oral conjugated estrogen appeared to be more effective in slowing the accumulation of interthoracic fat. As I say, I think that's a pretty soft conclusion. Using the same patients, again, Odoranikova studied the changes in epicardial and pericardial fat and the hormones that accompany changes in hunger. So in the upper frame, you have the two pericardial and epicardial fat measurements, and in the lower, you see the changes in leptin, and they did also adiponectin. I can't see it in my screen, but I believe you can see it. And they found that there were elevations, but they could not directly relate them, elevations in the hormones, but they could not relate them to the amount of fat. And this is in contradistinction to animal studies, which show a very good relationship between the so-called hunger hormones and the amount of accumulation of visceral adipose tissue. And for me, this serves as a really important reminder that if you want to study this subject in humans, you have to study humans. There are many discordances between animal models and humans in terms of the accumulation of a good or bad fat. So in conclusion, using all of these studies that came from the KEEPS and what we have heard from Augusta, firstly, menopausal women are estrogen depleted, and they may have an overabundance of androgens, especially those who go through a natural menopause. This is something that is particularly is not paid enough attention to, particularly by people who don't deal with menopausal women on a regular basis. And it's very important that we understand that this is real. And estrogen is a key element in the changes in superficial SAT or visceral fat, and it may be independent. The changes in fat distribution may be independent of the so-called hunger hormones. Estrogen depletion is associated with increased cardiovascular risk factors, and in almost every trial, the risk factors, the biochemical risk factors, are reversed by hormone treatment. Evidence from the prospective KEEPS trial, again, a prospective trial, randomized, that applies mainly to the subjects in the KEEPS, supports the possibility that women who are symptomatic could improve their deposition of fat if they were treated with hormone replacement or hormone treatment. And the salutary effects may extend into the dangerous intrathoracic fat. But this is very important that we study it in a prospective way with a much larger group of people and with different agents. So this is really in its infancy. In the middle of all of this, somebody plunked a whole group of different anti-obesity drugs that are going to be given to menopausal women. And we have absolutely no data on the interaction of estrogen and androgen with the effect of these drugs, and B, any long-term studies that include women with menopause. They are generally studies of women up to menopause. I'm not quite sure why that's the case, but it is. So we have to keep that in mind because this is going to become very much generalized. And so any things that we might say about estrogen replacement or hormone menopausal hormone treatment will be very much impacted by the effect of these anti-obesity drugs. So this means that we have to be quite cautious in determining whether we can use menopausal hormone treatment as an antidote to the conversion between menopausal obesity, and high-risk menopausal obesity. It's a very attractive idea, but it will be impacted by the anti-obesity drugs. So we're about to step off into a whole new side of the understanding of menopause and the protection against cardiovascular and other risks. And this will just have to wait. I thank you for your attention, and I wanted to just post the people who were important in the KEEPS trial, since I use so much of the data from the KEEPS trial. Thank you.
Thank you, Fred. A very, very beautiful lecture. Lot of data, mostly very important interpretation of the data. And I strongly support your concept that to study what is menopause in humans and what menopause is doing in humans, we have to go to humans and not to castrated animals and other species. And then now we have a lot of questions. Please, I suggest to all who want to put a question to write in question and answer. And then I will start reading the question, both for Professor Maturana and for Professor Naftolin. Then we have a question which you have already answered, Augusta, but she's from Domodar Mangalore Kini. I am a reproductive endocrinologist. We used to put great emphasis on BMI. Now we put more importance on and waist hip ratio. Do you think that we should do the same in menopausal women?
You're muted,
Open the microphone.
Augusta, you're muted. There.
Okay,
Yes,
thank
okay,
you.
okay.
I'm not sure if I understand the question. Please repeat.
Yes, then you know you have already spoken about the possibility to use the evaluation of body mass index and also to the waist hip ratio. Then the question is what it should, it's in your believing, what it should be better used in women at menopausal age, the body mass index or the waist hip ratio, or both of them?
Okay, and
Or
we
talking about-
have several available techniques to assess body composition, both in the clinical and the research level. Currently, my idea there is no single technique or ideal technique that can be safe and widely used. BMI is the most common method, but in the context of post-menopause women and transition menopause women, it's absolutely inappropriate because it doesn't evaluate the body composition. Maybe waist circumference is better than BMI, and waist circumference is an indirect evaluation only to abdominal fat, not thoracic or heart fat. Maybe in a clinical setting, better alternative can be DXA, and in select situations, in high-risk patients, as example, MRI or CT.
Thank you. Thank you very much.
I
Yes,
would add that,
please.
I would add that if you have a patient who is obese by any standard and has elevated risk markers for, say, lipids or any of the other elevated risk markers, that you can probably convince whoever is paying for the studies to allow you to do something more definitive, like either a CAT scan, certainly a DEXA. If you can use the presence of risk markers to explain why you want to pursue this.
Yes.
Thank you, Fred. And then now I have a question for you. Two questions I will put together. One is mentioning this from Asma Basha. She is told, do you think that the ectopic fat is a kind of protective action to have estrone in menopausal time? And together, another question is also related to the difference of estrogen. Are all estrogen the same, but the route of administration make the difference, as you mentioned that you have used the patch and the oral conjugated equine estrogen?
So the secret to all of this is understanding that estrogen is only the ligand for the receptor. The issue of estrogen action, or the understanding of estrogen action, is to be understanding of the receptor and how the receptor works on the genome to turn on or off certain proteins and so on. Every estrogen has to compete with other estrogens to get into the receptor and or to be pushed out of it. So, for example, estrone, if it's present in a really large quantities, you can displace enough estradiol that you start to see the effects of estrone via the estrogen receptor. But it is considered a weak estrogen because it doesn't have a lot of attraction for the estrogen receptor. You can make this scenario for every estrogen receptor ligand, including many of the compounds that are available clinically, and you have to work it out individually. The same thing goes for SERMs. Estradiol is a SERM, a selective estrogen receptor modulator. It's just predominantly agonistic. It gives you what we have conventionally thought of as estrogen action. Maybe if we started to study these things 30 years later, we wouldn't have even said that. But since it was the reference compound, we then said the reference actions when the estrogen receptor is full of estradiol are such and such. Now along 50 years later or whatever came some of the SERMs, which tamoxifen is probably the most commonly known. I remember meeting it when I was a graduate student in England. It was being used as an anti-estrogen to cause to try to induce fertility, and it's still in veterinary medicine. Tamoxifen is used to cause fertility by causing the gonadotropins to go up and getting more ovulation. So again, I guess my point is that the question can only be answered by looking at individual estrogens and kind of following them through as they get to the receptor, and then they find, and then the actions that they cause.
Thank you. Now is a question for Dr. Maturana. It's from Rafael Bedoya Torres, a friend from Mexico that I thanks to be with us today. Hi, Rafael. He writes, in addition to estrogen, what is the most appropriate therapeutic form to impact the reduction of the most dangerous cardiometabolic visceral fat and not only the less harmful subcutaneous fat? Please, and thank you carefully from the Mexico.
Yeah, thank you. I didn't understand the question, the specific question. It's about the other.
It's about what other, in addition to estrogen, what should be the most appropriate therapeutic form to impact the reduction of the most dangerous visceral fat and not only the less harmful subcutaneous fat. What other kind of treatment?
I think currently there are a new group of drugs, and maybe can turn these very promising drugs. And I refer a specific treatment with analogs of GLP-1.
Yes, we have also a question about that one. Yes.
Yes. There is a recent meta-analysis and published in obesity reviews that showed that the analog treatment reduce heart fat. The fat is very good, but the population of the study is not about specific our population in menopausal women. Maybe we must to test this, the use in this group of patients.
Yes, and also it's a very expensive treatment.
And I would add that the injectable compounds, semaglutide, what it is, these have serious side effects. And we should be very careful before we start on a long-term treatment with these. There are the earlier generation, for particularly the sodium and glucose transporter inhibitors. I forget what the name of it is, but this is, you take it orally. It has essentially no side effects or no serious side effects. And I personally would start with those rather, and it's not nearly as expensive as the other. So I would start with the older ones that have already been used widely, been shown to be safe.
Thank you, Fred. A very good suggestion. Then a question from you: what is the role of SERM and aromatase blockers in high risk menopausal obesity and cardiovascular disease?
So again, I would say that every estrogen that you know of and I know of is a SERM. They all go through the receptor and they modulate the receptor and its relationship to the individual tissue. Every tissue requires factors that individual organs make that decide what that effect will be. So you have to say, okay, I want to study, for example, in this case, fat. So I want to look at the effect of these SERMs on fat. It may not be relevant to other bone or other things. When you get to those, you will see that some of the changes that we talked about with conjugated equine estrogen or with estradiol might be seen. If it was up to me, I would try to start with estradiol because it's as well understood as anything, and I would try to use estradiol transdermally as the treatment. And we know a little bit about what it does to prevent the accumulation of visceral adipose tissue. There are other compounds that are on the market that are quite promising, estrogen-like compounds, SERMs, whether they're called estrogen or not, are very interesting in doing that. And finally, there is a whole family of genistein-driven plant estrogens that work by acting as SERMs, and I would encourage people to look at them as a way of treatment because these genistein derivatives are really active SERMs. Andrea published some wonderful work on what is it, DT56A, which is found in one of the over-the-counter preparations. I think I have to be careful about mentioning drug names or names, but you can look it up, Genizani and DT56A. This is an extremely interesting over-the-counter medication that, or over-the-counter compound that I would think would have a lot of promise for this.
Thank you, Fred, for mentioning that one. In fact, we demonstrate that it have also direct effect on the brain, production of beta endorphin and allopregnanolone, that they have effect on the bone. Then it have a series of effects absolutely similar to estradiol. And then now we have a nice question, Maria Augusta, for you from Marco Rossato. That you reported effects of obesity in menopause at heart level. What about the effect of obesity menopause on other organs, such as liver? And what about the effect of estrogen therapy on liver fat deposits?
Yes. We don't have large studies about liver steatosis, but there are increase of levels of fat mass in abdominal fat too. But unfortunately, we don't have specific effects in this population.
And then I would like to go with you, Fred, with a question. But what is the non-alcoholic fatty liver? Because the question from Marco Rossato go in that sense.
Well, I didn't understand the question.
What is the non-alcoholic fatty liver?
I was exactly going to say that obesity is the chief cause, except for alcoholism. Obesity is the chief cause of accumulation of fat in the liver. It's so-called non-alcoholic fatty liver. And this is not something to smile about. It is a serious disease, and people who have this kind of effect on the liver will ultimately get cirrhosis, and I suppose could die, but the liver is so important in detoxification and in the furnishing of various proteins that you start to see a whole ripple effect on the entire body economy. So non-alcoholic fatty liver is a serious problem. It is related most commonly to obesity, and everything that Augusta has told you about should scare your pants off about this.
Thanks. And then now we have Celia Wernicking. She make two questions. She divide two questions. Augusta, can you write it up? What might be the physiology that drives this mechanism, glucose, hormone, etc.? And what intervention would you propose to help women avoid this physiology, except menopause hormone therapy? But she have forget that this happened because women are deprived from estradiol, as Fred was explaining. Please, can you make your answer, your comment about that?
Okay, I think we need a lot of strategies during the life cycle, not only the menopause transition. The women get weight in along of your life. I think gestational weight gain is associated with maternal weight retention and development of obesity in future. If you see the graphs of increase of weight in women, the increase of weight, there are inflection of the curve during the menopause transition, but it can start a little before this. Then menarche is a other point of vulnerability, pregnancy, postpartum, and then menopause transition is very important.
Thank you. And Fred, now for you from Engin Oral. How about the polycystic ovary patients with the menopause?
So, I might have expected such a good question from Engin. I'm trying to think it through. Of course, a certain number of women who have polycystic ovaries become obese, and these are generally, well, they are premenopausal. So the question is really not about menopause, it's about premenopause. It's still an important question. I don't know the answer in terms of accumulation of visceral adipose tissue and so on. But remember that these women who have who have polycystic ovaries, they also have quite a bit of estrogen. So we really need some studies to define this. I don't think that it's as simple as it sounds, but it's definitely worth somebody doing some CAT scans in polycystic ovaries.
And the same engine asks you, what is the effect of progestin on abdominal obesity?
So progestin in general, first of all, we have to make the distinction between progesterone,
yes,
which is the classical progestin, and I will respond that way, and other progestins, many of which are derivatives of androgens. The progestin receptor binds both, and the androgen receptor, they are promiscuous in terms of their recognition, their binding of androgens and progesterone. So you have to be very careful. If we are talking about progesterone, the key effect of progesterone is to inhibit the expression of the estrogen receptor. So when you have high progesterone, pregnancy is a good example, you inhibit the estrogen receptor, and that's why you don't go into labor. At the end of pregnancy, you stop in humans, you stop having an effective progesterone receptor, you make more estrogen receptors, they induce gap junctions, now you go into labor. So that's progesterone. Now, if you talk about progestins, the most common one, of course, is medroxyprogesterone acetate. This is an adulterated androgen. And when it gets into the progestin receptor, or more likely the androgen receptor, it starts to act like an androgen, and you start to see not only progesterone effects, but you see androgenic effects, some of which are quite toxic for the heart.
Thank you very much, Fred. A beautiful response, a very important words on the topic. And then now we have a question, Augusta, for you. She's from Irina Timenko. Thank you very much for both presentations. Please, what about the effect of diet and exercise, intense or moderate, on obesity and steatohepatosis, as well as on lean body mass in postmenopausal women?
I think that lifestyle is very important to in this phase, but I don't. I think is the exercise is a good way to increase lean mass. Have a good diet. I think it's very important too. I don't have knowledge about a specific topic and VAT and menopausal women. But it is a good way to have a project.
Thank you.
I would like to point out that anything that is effective in reducing body fat is going to only be healthy if you increase lean body mass, muscle. So anybody who goes on diets or who gets ill or whatever that reduces body fat must have compensatory increase in their muscle, or protect their muscle. Muscle is a very important metabolic organ, and they work together. You must always, when you are talking about weight loss, you must always consider maintaining muscle.
Yes.
Yes, and
I
then
agree.
this is important. We have also a question concerning to that one that I want to read. Is from Ivan Romero. What about obesity-associated sarcopenia? Is there any benefit of menopausal hormone therapy in changing body composition as well? And he bring his regards from Nicaragua.
For me or Dr. Naftolin?
No, or any of you that want to ask to answer about sarcopenia, because also sarcopenia is a phenomenon which is associated and who depend not only from what happened in the ovary, but also for what happened in the growth hormone leg. You know, we have also reduction of production of growth hormone and IGF-1 going on at the same age, and also reduction of androgen production from the adrenal gland, which is simultaneous to the in that period of age. And both of these factors, the lack of growth hormone and IGF-1 and the lack of androgens, they are strongly supportive for the evolution through the sarcopenia. What do you believe, Fred, about that?
I think you already gave a better answer than I could.
Thank you very much. Now we are approaching but we are still a lot. And then we have some other question that I would like to put is, okay, one, she's Michelle Moreau. She asking, KIPS trial, you were using 0.45 milligrams CEE instead of 0.625.
Yes.
And then she asked if this reduction, this low dosage of CCE can be considered important in the results that you have obtained in the comparison to 50 microgram transdermal patch in comparison to the bigger normally used dosage?
Yes, of course. That's, I mean, this is a key point in understanding the use of randomized clinical trials. The results that I've shown you are only really directly applicable to those subjects. At any randomized clinical trial, you must always say, okay, this is applicable. Now, could I make some changes in what I would do on the basis of that? Yes, you could give more CEE. We decided that this might be thrombogenic. And so this was how we decided the dose to avoid intravascular thrombosis. We also, of course, used a cyclic regimen rather than the constant regimen. I was on a boat in Toronto with the person who worked at that time for AIRS, and that was when he decided to give the NIH Prempro rather than Premarin and blah blah blah. It was a marketing decision. It wasn't a scientific decision. He was an internist. He's passed away. He was an internist. I don't think he even understood what hormones were. But I was on the boat with him in Toronto when they made that decision. It was a horrible decision to put Prempro into the women's health initiative.
Thank you, Fred. This was a very critical moment. And then now another question for you, Augusta, is from Silla Wernicking. She's asked an interesting point. She writes, sleep is extremely important to keep good weight and metabolism. And sleep disturbances that women have in perimenopausal and menopausal time, do you believe that they can have any role?
I think sleep is very important. It's very, very important. It is a symptom very common in the practice clinical. And we have some questions about the treatment of insomnia or sleep disturbance during this period. I think we know that hormone therapy can be a good way, especially in patients with hot flushes. It's a good effect. And I think is a very important question to treat sleep problem to avoid get weight, because this is intrinsic in the pathophysiology of get weight.
Thank you. And then now from Temo Celis. Hi, Temo. Thank you for being with us. Is for Fred. He's asking, what is the relation if blocking FSH induces thermogenic adipose tissues and reduces body fat?
I would guess it depends on how you block the FSH, but I honestly don't have an answer. There is a very long history of people trying to look at the effect of gonadotropins on fat, direct effects. But as far as I can tell, it's mostly animal studies and not very conclusive.
Yes, I agree also on that one. And then Fred, for you, from Nicholas Tsakalakos, he asked if you have data on the effect of Tibolone on menopausal obesity and fat distribution.
I don't. Maybe Augusta may have some.
Augusta, you have any data on Tibolone?
Timbolone. I don't have experience with Timbolone.
Then I can tell you, we have some data on Tibolone. Tibolone reduces the insulin sensitivity, and then by that effect, it have a pro-adiposinetic activity, and then cannot be given in individuals who have already some disturbances of glucose metabolism. Then, okay, then a question again is there were other one on the use of Ozempic to treat obesity. You know, now Novo Nordisk have make a huge amount of money touching the problem of human obesity and then human overweight. And then we had several questions that I have not written Ozempic for the treatment of perimenopausal obesity. And already Fred have given a comment, and you also have given a comment about that one. Then I would like to ask you, we are going on with the time, I would like to ask you to make a final comment about on your presentation and also on the question that we have received. I think ladies first. We will start with Augusta, and then Fred will close this fantastic webinar. I have not read all the comments that we have received and comments thanking both of you for the beautiful presentation and beautiful level of the discussion. Then Augusta, please.
Thank you. I would like to thank you. The opportunity is a great opportunity for me, and it's a good talk. And it's my pleasure to co-present with you, Dr. Genazani, and with Dr. Naftolin. And I hope to have future sections for discuss this.
Thank you very much. Fred, your comment on these topics. You know, you were mentioning the data starting from the mistake in the WHI planning, selection of the patient and selection of the drugs. And then you are also terminating with the new hopes. But you have to mention also that the WHI have stopped the new investigation on that very important chapter, which is menopausal transition, early menopause and postmenopause and therapies, and what the lacking of estrogen is doing on women's body, on the wall, from the brain to the legs. Please.
I remember when I met Andrea in Washington, when we were first protesting the first flawed evaluation of the WHI, and they had invited comments. Andrea was there with his hand up, and it was very important. The WHI has really corrected most of its flawed data, and it has some wonderful studies that have been done, but and they all fit with the things that you heard today, and not with the terrible stuff that came out in 2002. But the damage has been done. I don't believe that we will ever know how many women suffered or died as a result of people not giving estrogen to postmenopausal, giving menopausal hormone treatment to menopausal women, particularly women who are on tamoxifen, which has cured nobody, and causes endometrial cancer, and all kinds of menopausal symptoms, all over the failure of the WHI to present their data fairly, originally, and still unwilling to give the raw data to anybody. So I think this is a really sad chapter in our history as investigators, and so on. I would summarize by saying that obesity is not a choice; it is a disease. And as our colleague says, you don't live with with obesity, you die with obesity. And we have to look at it more closely. Estrogen and menopausal hormone treatment in general may be quite useful in preventing the move from menopausal obesity to high-risk menopausal obesity, but we will not know that for a long time because of the intervention of these anti-obesity drugs. We need to begin almost immediately to get people to study menopausal women with and without menopausal hormone treatment and the use of these drugs. These drugs are going to be with us for a long, long time. The ones that are already on the market that are not injectable are safe, and I would advise people to use them rather than the injectable ones because they have been shown to be side effect free. The injectable hormones have been purposely made by the manufacturers so that they can maintain their patents. Their patents depend on the syringe, the way that the injection can be. So they are hoping to drag out their patents for years by changing a little bit about how they're injected. These could be given other than by injection. This is the manufacturers trying to fool you, but you don't need that. They have side effects. You don't need to go to them. You need to start with particularly, I think the best one for most people is the sodium and glucose transporter inhibitor. I think that is very important. Estrogen is going to continue to be important for women, and so it needs to be tested with them.
Thank you, Fred. Thank you, Fred. Thank you, Augusta. We are now have terminated our time. You know, we had a huge number of questions and huge number of people with us. Thanks to both of you. And then I would like to invite all our participants to join next 20th of September. We will have another very important webinar from symptoms perception to a final diagnostic. What can be done to optimize the patient care? And we will have Professor Qinji Tian from Beijing and Professor Steve Goldstein from New York. And we will be happy for all of you if you can join us. And then I remind to you that we will very soon present the preliminary program of our 21st World Congress of Gynecological Endocrinology, which will be in the magnificent scenario of Florence, where this beautiful painting of Botticelli, La Nascita di Venere, is presented at the Uffizzi's Gallery from 8 to 11 May 2024. Thank you, Augusta. Thank you, Fred. All my regards to your family, to Marci, and to all our friends. And thank you for being with us again another time. You have done a great job, Thank you. Arrivederci.
Arrivederci.